Yeah, but I'm in Florida. This one is good. Like the later classes in Deerwood. I don't know what it was up Deerwood. The professors had everything like this. If I could lose it. So I'm like, no, I'm good.
My AP1 professor was from Deerwood.
Who was that?
Cheeseman. Dr. Cheeseman.
Deerwood in the daytime is fine. It's just the night. It's like they lose it. Like they the whole day is become so much than I dropped two. It was AP1 and AP2.
Yeah, they usually vary from like 8 to 12. Yeah.
Everything.
I've only done like cardiovascular ones for this.
Another one.
Yeah. Because even whenever you go back, you actually go back and go to the so
go to UNF and then
oh, yeah. So there's a second one.
Non-conventional students. So we got kids and we're supposed to see the guy. We'll tell them, oh, don't stay connected on the phone. I was like, okay, all right. I was like, nah. But one girl, she's like a single parent. I don't have kids, but stop. That's the if you don't have kids, because what happened is you keep that woman from whatever she was having, look, so now you have correct.
Alright, so quick reminder of what we discussed last time. You remember how would I be able to determine whether I have enough blood pressure or not, whether I have low or high mean arterial blood pressure. What kind of receptors would be able to identify whether you have a high or low mean arterial pressure? Okay, can you remind me first, what is mean arterial pressure?
When I start with the pressure plus a third of pulse pressure.
Diastolic plus 1/3 of the pulse pressure, which is around 93 on average, right? But what did create this pressure? My artist, can you remember? Yeah, flow again. And we mentioned that we have three factors that will affect my mean arterial pressure, and those are so cardiac output, which is the amount of blood that you pump per clip. This is your blood flow. My blood flow on here. This is my cardiac output. And this will be multiplied by the resistance applied by the wall of your vessels. And this is what we call the peripheral resistance. So again, two factors here that we discussed. The first one is the blood flow, which is my cardiac output. And the second factor, the second major factor here that will affect your blood pressure is going to be the resistance applied by the vessels on system. Having flow and resistance, this is what creates the pressure. The force by which we're going to be pushing the wall of the vessel out. This is my arterial blood pressure. Arterial blood pressure. Another factor which will contribute in here, but we can consider it as a separate factor, contributes in the amount of blood that I will be pumping per minute is going to be my blood volume. So, three major factors, not only, but major. Not only. Those are not the only factors that will affect your mean arterial pressure, but those are the main ones that we're going to be considering here. Alright, so the first one is going to be cardiac output. Second one is going to be the peripheral resistance, and the third one is going to be the blood volume, which contributes in determining your cardiac output. You remember how did we calculate the cardiac output? What times what? Stroke volume times heart rate. Stroke volume, and if you remember, what is the stroke volume? This is the amount of blood that we pump per unit. Beat. And how did we calculate the stroke volume? Can you remind me? We did check the size of the ventricle at the end of relaxation, and we did subtract the size of the ventricle at the end of contraction. What did we call those two sizes, those two volumes? This one is my end systolic volume, and this one is my end diastolic volume. This is the end. This is the volume of the ventricle at the end of the relaxation, end diastolic, and this one is my end systolic volume at the end of contraction. When you subtract the volume at the end of contraction from the volume of the ventricle at the end of the relaxation, this gives you the volume of blood that you did pump in this single beat. This is what we call again my stroke volume. So what are the factors now that will be contributing in determining your mean arterial pressure? We've seen cardiac output, which means heart rate and stroke volume. And stroke volume, which means end diastolic and end systolic. So all those are going to be affecting your blood pressure. So if I have an increase in the end diastolic volume, what's going to happen? Increase in stroke volume. And as you increase stroke volume, you increase cardiac output. And as you increase cardiac output, your blood pressure will go up. If I did reduce my end systolic volume, what's going to happen? Your stroke volume will increase. Increased stroke volume will increase your cardiac output. Increased cardiac output will increase your blood pressure. So you can see here, many factors will contribute in determining and affecting your mean arterial pressure. Again, what are we trying to get? We are trying all the time to maintain a normal blood pressure. We don't want to have a low or a high blood pressure. We don't need to get high blood pressure. Why? Why you don't want to have a high blood pressure? Want you have better delivery of the blood. If you keep squeezing your vessels, you're going to have a higher pressure. Blood will flow faster, better conduction of the gases, better conduction of the nutrients, so I will have a much better performance. What do you think? I will exactly put lots of pressure on my heart. Because remember, if I have an increased pressure in the vessels here, my heart needs to have a much higher force to push the blood against this high pressure that it needs to overcome. So what we call the did have this hypertension for years, which is not controlled. Alright, so this is one of the reasons why you don't want to have a high blood pressure. You're going to have much more complications to having a high blood pressure, like retinal hemorrhage, for example. So I would have rupture of the vessels, and one of the sites where I might have bleeding due to rupture of the vessels due to high blood pressure is going to be my retina. So I might have blindness as a result of this high blood pressure. I might get rupture of one of the vessels in my brain, intracranial hemorrhage. Alright, so you don't want to have a high blood pressure. And at the same time, you don't want to have a low blood pressure. Why? Because you need to have a normal blood pressure in order to get the blood to the inside of your tissues, passing through the capillaries. And remember, your ability to get the blood to move within your tissues, this is what we call, any idea? Tissue perfusion. And again, why do I need tissue perfusion? I need it, for example, my lungs to perform the air exchange, to oxygenate my blood. If I don't have tissue perfusion of the lungs, it's like as if I don't have lungs. No exchange will be taking place. In order for my organs to get this oxygen and release the carbon dioxide, get the nutrients and release their wastes, I need to have tissue perfusion, or those organs will be infarcted. So I would have renal infarction, a splenic infarction, brain infarction, heart infarction. Part of the tissue will die because simply it's not provided with oxygen, it's not provided with nutrients. All this will reduce its ability to maintain life. Alright, so I need to have normal blood pressure to keep the blood moving inside the tissues. Tissue perfusion, to have a normal tissue perfusion. So generalized regulation. In order to keep my blood moving at enough force, I'm detecting the blood pressure, whether it's increased or it's decreased, by two major receptors. One that detects stretch and one that detects chemical changes of the blood. Seeing the other receptors, we've seen chemoreceptors last time. If you remember, if I have an increased stretch of my arteries, this means I have high or low. What do you think? High blood pressure, high arterial pressure. If I have an increased stretch of my vessels, this means I have a high blood pressure and it needs to be reduced. So baroreceptors will send the signal to your brain, and your brain will respond by dilating the vessels. Why dilating the vessels? Because if I have high blood pressure, I want to reduce the resistance. Having a dilated vessels will apply much less resistance against the flow. And if I apply much less resistance, what's going to happen to my blood pressure? Decrease. So again, how will I be able to decrease my blood pressure under the effect of baroreceptors? You dilate the vessels. And when you dilate the vessels, you're going to have less resistance. And if you reduce resistance, so arterial pressure equals to cardiac output times peripheral resistance. If you're reducing the resistance, what's going to happen to the pressure? Drops. So if you have 10 equals 5 times 2, if you drop this 2 to 1, so it will decrease. What if I did detect by the baroreceptors located in my large arteries that I have a reduction in the degree of stretch? I'm not having enough stretch of my large arteries. So how will I respond? I will be constricting the vessels. And why do you constrict the vessels? To apply more resistance. And when you apply more resistance, what's going to happen to the pressure? Remember the hook, when you compress the end of the hook, water will flow faster. It flows at a higher pressure. See on here, so you're gonna be responding to this reduction in the degree of stretch, which means low blood pressure, by performing vasoconstriction. What vessels would you constrict? It's a generalized effect. I will be constricting all the arteries. I have a drop in my mean arterial pressure. I don't have a decrease or an increase in the amount of blood reaching one specific organ. I have a drop in all the blood pressure in your lungs. So you have a generalized regulation here. It's going to be affecting all the vessels. Alright? See, chemoreceptors. If I have high carbon dioxide, if I have drop in my blood pH, this means what? This means I have a high or low blood pressure. What do you think? If I have increased carbon dioxide, this means you were able to do enough tissue perfusion in your lungs?
No.
If I have high carbon dioxide, this means I failed to get rid of the carbon dioxide. And if you fail to get rid of the carbon dioxide, how would you respond? I have a low blood pressure, so how would I respond? You constrict. Generalized constriction will increase your resistance, and as you increase resistance, you increase pressure. We'll see generalized regulation, but this time it's not the brain who's acting now. It's going to be my glands. It's a hormonal regulation. We've seen three hormones that were affecting the diameter of my vessels. Generalized regulation. Those are mine. Angiotensin. And remember, angio is vessel. Tensin, tension. Constriction of the vessel. We've seen other hormones. This is mine.
Atrial diuretic.
Anti-diuretic.
Atrial native.
Hormone.
The
Loss of water in urine.
the natriuretic peptide.
So, am I increasing? What do you think? From its name, natriuretic peptide. Would you increase blood pressure if you're called natriuretic peptide? What do you think? Will it decrease or increase? Just from its name, it tells you I am moving what in the urine? Sodium. So I'm expecting this hormone to be increasing or reducing my pressure. What do you think?
Reducing.
Reducing my pressure. So you see here, natriuretic peptide is going to be reducing your blood pressure. So if somebody has hypertension, we tell the person who has hypertension to reduce the intake of sodium. So what do you think is a hormone that gets rid of the sodium? It's going to be reducing your blood pressure. Natriuretic peptide, one of its mechanisms of action is going to be to get rid of the sodium as well as vasodilation. So it's going to be dilating the vessels also to reduce my blood pressure. What is the next hormone that you mentioned? Antidiuretic. What else? Norepinephrine and epinephrine. But when you look at this diagram that we've seen last time, so some of you did get confused on here. How the norepinephrine and epinephrine are going to be constricting and dilating at the same time. So green arrow means to dilate, and the red one is to constrict. How would I be constricting and dilating at the same time? How do you justify this? So what is epinephrine and norepinephrine? Where do you release them? Under the effect of the sympathetic nervous system. So when you activate the sympathetic nervous system, you're going to be releasing the norepinephrine, which is a neurotransmitter. You're going to stimulate the adrenal gland to release both epinephrine and norepinephrine to enhance the sympathetic activity. But how come will you be dilating vessels and constricting vessels at the same time? Does this make any sense?
Well, you can dilate some vessels and constrict other vessels to redirect the blood to wherever the body needs it.
Exactly. So if I am in a fight or flight situation, I don't want the blood to go to my gastrointestinal tract. I want the blood to be shifted to my muscles, right? So what do you think I will do as to the blood vessels in my muscles? Constrict or dilate? Dilate. And to the ones that will be going to my gastrointestinal tract, my kidneys, I will constrict. So how the same signal will have two different effects, because each of those organs will have different receptors. So yes, this is the same signal. I will send the same signal to two of you, but both, so you will understand two totally different things. The way you perceive the signal is going to be different. So I might have an effect totally different from another organ according to which receptor I will bind to, which receptor this organ will have on its outer surface. All right, that's why you're going to see epinephrine and norepinephrine. I have two arrows. One is green, one is red. Constriction and dilation according to my needs. All right. Questions? We've also discussed the autoregulation, and this is mainly concerned with localized regulation, tissue perfusion. If I'm not having enough stretch in one of the vessels that will be supplying a specific organ, this means it's not getting enough blood supply. So what would you need to do? Dilate or constrict? If I'm not getting enough blood into my kidney, would you like to constrict this artery, or you want to dilate?
Dilate.
If I don't get
Open it
enough
up.
stretch, this means
Open it up.
I don't have enough blood coming in. And if I don't have enough blood coming in, I will need to
Open it up.
constrict or dilate.
Dilate.
Constrict, dilate. So, for those who did choose constrict, congratulations, you killed your patient. Because we are supposed to be patient, right? So, I'm already receiving two small amounts of blood to the kidney. If you constrict, what's going to happen?
Cut the
Less
blood flow
will
off.
be problem. Yes, you might constrict other vessels. You might constrict all the vessels in the body, but you dilate this one. Alright? If you want the blood to go to the kidney, for the
Open it
kidney
up.
to function, you need to dilate. And this is my myogenic regulation. Myogenic. If I have less stretch, I will respond by dilating. And this is exactly the opposite of what we've seen here in the generalized regulation. If you have less stretch, you constrict it. Here is the opposite. If I have less stretch, I will dilate. Alright? What if I'm receiving too much blood to the kidney? What do you think we need to do now? Now you constrict. If I have increased stretch of the vessels, This means I'm getting too much blood, so I want to reduce this amount to not have a rupture of the capillaries inside this organ. So you're gonna need to constrict. So you dilate whenever you receive less blood, less tissue perfusion. You constrict whenever you receive too much blood. Right? This is the difference again between auto-regulation and the generalized regulation under the effect of the nervous system. Anybody is not convinced? Questions? All right, so what do you think about this question? We answered it before. If you want the blood to move to skeletal muscle, you will need to open or close the precapillary sphincters. What do you think?
Both.
You open the precapillary sphincters going to the muscles, yes or no?
Yeah.
So would you close the precapillary sphincters that would be located in the less important organs?
Yes.
Yes, so this will allow you to direct the blood from the gastrointestinal tract, for example, to your skeletal muscle. So both here, A and B. Alright, so how will I be able to perform the exchange in the blood and my cells? It's according to what you're trying to move between the blood and the cells. If I'm trying to move gases, for example, those are easy to grab, and then you're troubled by diffusion. Gases are so easy to trouble between my blood and my tissues. They will simply travel through the membranes of the endothelial cells of the capillaries. They don't need a carrier, they don't need a channel for them to travel. They will simply travel from high pressure to low pressure by diffusion. I don't need to consume energy to get the oxygen. I don't need to consume energy to get rid of the carbon dioxide. Those gases will travel from one side to the other by diffusion. What if I'm trying to transport a lipid soluble molecule? What do you think? So I did inhale insecticides. What's going to happen? This is a lipid soluble molecule. So what's going to happen? Or I did get exposed to insecticide, I got insecticides on my skin. So what's going to happen? It's a lipid soluble, so
It's gonna break down. It's gonna break down and just die out.
it's going to pass through the plasma membranes by simple diffusion.
Yeah.
Remember, what is the structure of the plasma membrane? What is the main component that forms 75% of the plasma membrane structure? Phospholipids. And remember, you have a polar head and non-polar tail. And polar head is going to be hydrophilic, loves the water. But the non-polar tails, which are fatty acids, those are hydrophobic. They hate water. And they hate anything related to water. So if I'm dealing with a water-soluble substance, I will have a problem. I need a carrier or a channel to travel through the plasma membrane of the cell. But if I'm dealing with a lipid-soluble substance, would I have any barrier for me to pass travel inside the cell? No. So if I got exposed to insecticides, for example, those insecticides will directly pass to the inside of my bloodstream and will be conducted to whatever organ. They will travel by simple diffusion. Direct diffusion here through the cells. Alright? What if I'm dealing with a water-soluble substance? and those endothelial cells are not permeable for those water-soluble substances. How would you be able to transport those solutes? Something like glucose, amino acids, something like sodium, potassium. How would I be able to move them between the blood and the cells?
Fenestration.
Yeah. According to what kind of capillaries you have. If you have continuous capillaries, the only way for you to perform the exchange of those solutes is going to be between the cells, intercellular clefts. If you're dealing with a type of capillaries that will allow a higher permeability, you're going to be passing through the fenestrations. So if I'm dealing with a water-soluble substance, it will be able to travel between the cells or through the fenestrations of the cells. What if I'm dealing with larger compounds? I need to transport them by vesicular transport. I will be picking up this large fat molecule to the inside of the cell in a vesicle by endocytosis. And then I will be transporting this vesicle to the other side of the cell, and I will release the contents to the inside of the bloodstream. So if this is an intestinal cell, and you did just eat butter, so how would you be able to transport this dense molecules of fat? You transport them as large compounds, and those large compounds cannot pass through the fenestrations, cannot pass between the cells. So you're going to need to engulf those large compounds from one side of the cell and release them from the other side. Why you don't break them down? Because if you keep them in the simplest form, they will start to deposit in your bloodstream. So you need to keep them attached to proteins for them to become soluble. That's why they will have to be so big. For them to be soluble, I have to add protein to them. And if I'm adding protein to them, they will be large in size. They will not be able to travel through fenestrations or intercellular clefts. Need what kind of transport again? My vesicular transport. Vesicular transport. So, blood flow through the tissues is called what? Diffusion, tissue perfusion, autoregulation, none of the above. Blood through tissues, this is
Tissue perfusion.
tissue perfusion. Alright?
Tissue perfusion.
Tissue perfusion. So blood flow again into the tissues means tissue perfusion. And how do I maintain a normal tissue perfusion? Having normal mean arterial. In order to maintain a normal tissue perfusion, I need to have a normal blood pressure. Alright, so moving on to the disorders here related to the blood vessels. First disorder that we are looking at today is going to be the varicose veins. So varicose veins, those are dilated bulging veins, most commonly going to be located in the leg veins. Leg veins will be dilated, bulging, filled with blood. Other common sites would be in the spermatic cord that would be attaching the testes in males, and in the anus, anal veins also might be dilated. Why those sites? Why do you think? What's common between the leg veins, the testicular veins, and the anal veins? They are far from the heart. It's one way, yeah, one thing. What else? What else is common between those three veins? A lot of pressure from
movement?
Muscles.
Muscle movement?
From muscles?
When the muscles contract, they should be pushing the blood so up, so they shouldn't have been accumulated down. Right? So having a stronger pressure, let's say in my legs, it should actually reduce the chances of developing varicose veins.
Because it's farther away, it's.
Far
it's
away
farther
from the
away
heart, so
there's lower
you're
blood
gonna be
pressure.
doing what?
Yeah, it needs more.
Since it said like leaky valves, since they're far away from the heart, the valves won't be able to like push the blood up, so it would stay. It would stay in the vein.
Yeah, but if I have this defect in the valves, why I don't have those varicose veins in my arms?
Because it's not that far from the heart.
It's
Close to the heart.
so for example, why I don't have varicose veins here?
It was something that we talked about last.
What's common between spermatic cord veins, those are called the papilliform plexus of veins, anal veins, and the leg veins, is you're trying to move the blood against the gravity. So the gravity is pulling you down. Compared to the arms, you can move them around, you are not essentially moving against the gravity all the time. Alright, so what's common here between those veins? They are trying to move the blood back to the heart, but against the gravity. So there is a force that pulls the blood down. Those patients, where is their problem? They have defect in the valves of the vein. So they have weak collagen, and as they have weak collagen, the fibrous connective tissue that build up those valves will be defective. So the valve will be leaky. So as I try to push the blood up against the gravity, the blood is going to be
Pull it back down.
every time I push the blood up, some of it will go down. And remember, do I have a thick layer of muscles in my arteries, in my veins?
No.
No.
Isn't that pretty much what
I
you
have a
said?
thin wall of the veins. Do I have a high or a low pressure? Low pressure. Am I able to accommodate high pressure of the artery? No. So what's going to happen? If you kept adding more and more and more blood to those veins, they will not tolerate this high pressure and they will start to bulge. So the vessels here will be bulging and I will form sacules filled with blood. What is the problem here? That I might have pigmentation, hyperpigmentation of the skin in the lower limbs. I will have pain. Why would people with varicose veins will have pain in their lower limbs? Why do you think? Any idea?
Since the vein got bigger and you're adding the same amount of pressure, it will be like too much pressure on the vein, which causes more.
Where do you feel the pain?
On the saccules.
So do you feel the pain in here? Because of irritation in here?
You feel
I feel the pain in the muscles. But if I've got pain in here, this means I
I think
have
that's going to
the
be
infection.
affecting your nerves and the muscle.
But I have a problem in the muscles. My pain is in the muscles. Why do you think I would have pain in the muscles?
The nerves.
Nerves. You're going to be compressing the nerves. But actually, those sacs of blood are bulging to the outside. You have nothing on the outside, so you can't see them from the skin.
Okay.
What do you think?
It's because the circulation is not going.
Yeah, so I have a problem with my circulation, but what's going on with the circulation? What do you think?
Is it slowing down? Because,
Slowing down. Why?
Because it also has to go to the.
So you see here, if this is my
So it's
tissue,
a little
this is
numb and
my muscle,
tingly.
let's say. You're getting blood to the muscle by an artery or a vein. You're moving away from the heart or to the heart? Away from the heart. Increase the artery, alright? So carry oxygen into blood, like this, right? Then the artery will divide into capillaries inside the tissue, right? And then you're going to be draining this blood after you perform the exchange by the venules that would be building up my vein. So if you have congestion in here, high pressure, would you be able to leave? No, so the blood is going to be congested in here as well. And if the blood is congested within your capillaries, would you be able to get new blood into your muscle?
Not efficient.
So I won't be able to add sufficient amount of blood because I have poor drainage. So yes, I have normal blood pressure, but it's facing with an opposing pressure because of the congestion of those veins. So the blood will slow down getting into those muscles. So if I'm not getting enough blood, this means I will have less oxygen delivered, and if I have less oxygen, less ATP will be released by the muscle cells, and if less ATP will be produced, this is what causes muscle fatigue and pain. All right?
Is that what causes lymphedema?
Lymphedema is it's a different problem. I have a problem in my lymphatics, which is a different circulation. So this is a totally different circulation other than the vascular circulation. We're looking here at blood. So if I have problem in the drainage of the lymphatics, it's gonna also result in accumulation of fluids within the lower limbs because of poor drainage. But the affected system is gonna be a different one. I'm affecting the lymphatic system rather than the vascular system. All right? Questions? All right, so another homeostatic imbalance, this time is related to the blood pressure. If I have low blood pressure, below 100 millimeter mercury during ventricular contraction, so systolic blood pressure is below 100 millimeter mercury, I have hypotension. Hypotension. What is the problem with hypotension? And why a person might develop hypotension? What do you think?
Not enough tissue perfusion.
Yeah, so this will result in low tissue perfusion. Yeah, but why will I have it? What are the risk factors for having hypotension? So,
What's the risk factor?
yeah, what causes a person to get hypotension?
Like kidney.
Blood loss might cause blood loss, but having chronic hypotension.
Low nutrition.
So every day I have low blood pressure.
And like anemia.
Anemia won't affect the pressure.
Yeah. Low salt. Low
Eating fats will increase the blood pressure.
not enough.
Not enough sugar.
Alright, so this will tell you that life is fair. Alright? So those are healthy people who have been exercising throughout their life, so they don't have a cardiovascular problem. But they did get old now. So what's going to happen to the muscle bulk? Decrease. So if I decrease the muscle bulk, what's going to happen to the venous return? Getting back to my heart. The amount of blood that you get back, if you don't have large muscles, what's going to happen? It's going to be decreased because you're not squeezing those veins. And if you didn't squeeze those veins, you're going to have less venous return. And if you get less venous return, what's going to happen to the amount of blood that you will be pumping? Stroke volume?
It's going to slow down.
Decrease. And if you decrease stroke volume, what's going to happen to the cardiac output?
Decrease.
Decrease. And when you decrease cardiac output, what's going to happen to your blood pressure?
Sky high.
Decrease.
I mean, low.
Alright, so this is a healthy person with no cardiovascular problems, but he is just getting old. So if a person didn't have a disease, he will get another one. All right? Life is fair. All right? All right, so why another person who is not that healthy won't get hypertension? Because he will have hypertension.
Can't win.
All right? Why? Because one of the most important risk factors here for hypertension is I did accumulate fat in the wall of the vessel. I was eating poorly, and I did get lots of fats, lots of carbs in my diet. Over time, this fat will accumulate in the walls of my artery. And if you remember, what was the blood pressure during ventricular contraction? Arterial blood pressure during ventricular contraction, systolic blood pressure is around 120 millimeter mercury. And remember, during ventricular relaxation, what your blood pressure will be? 80 millimeter mercury. All right. So, you remember, how did I get this pressure when my heart is not pumping blood out? How would I have 80 millimeter mercury? Because of recoil of my elastic arteries, right? So during ventricular contraction, what happened to your elastic arteries? They did expand, and then they will recoil to push the blood when my heart is relaxing, right? So if I told you I am accumulating fats in here, and due to this large amounts of fats I'm accumulating in my vessels, what's going to happen? Would you be able to expand the vessel? No. And if I'm not expanding the vessel, so what happens to my volume? Rather than being this size, by expanding, it's going to go down. So what happens to the volume of the vessel? Decreases. And when you decrease volume, what happens to pressure?
Increases.
Hypertension. All right, so if a person didn't get hypertension, he would get
Trying to formulate this question. So they say that African Americans normally have higher blood pressure. Hereditary, is that?
Can you repeat that again? What I didn't hear, Captain America.
Oh.
I'm not sure where
African Americans, they say they're supposed to have higher blood pressure through hereditary. Is that?
Yeah, I have a predisposition to add more here, to add more fats in here. So I have a higher predisposition to form a type of fats that puts me at a higher risk of developing atherosclerosis. One thing. Also, the other thing that I would have a higher tone in the blood vessels. So if I have a higher tone here, this reduces my ability to dilate.
Okay.
All right. So this puts me at another risk. All right. What genes exactly are triggering this? Those are theories. We don't know the exact genes that are predisposing for the hypertension. All right, but according to studies, we see this number of people share those characteristics, and we've seen that those people are having this kind of disease. So we can build a theory about it, but we can't say it's a genetic disease simply because other people get it. Also, we were not able to identify the specific gene on the DNA that will be responsible for the disease itself. All right? So saying, for example, it's a genetic predisposition, this means that we did find this gene in a certain group. And there will be theories about it. So, for example, when I say people with lighter skin color, they will develop, they are at a higher risk of developing skin cancer. So this is a theory, and we know a risk factor that will be present in having light colored skin, that I do have less melanin. So, and if I have less melanin, I'm not absorbing the ultraviolet rays. And if I'm not absorbing the ultraviolet rays, I am applying more irritation to the skin. But while not everybody will be getting, we have some genetic predispositions that we don't exactly know about. So we can say it's a risk factor, it runs in families, it has a genetic predisposition, but we cannot say it's a genetic disease unless we determine exactly what are the specific genes that are resulting in the disease. All right? Does this answer your question? Get closer?
Well, I didn't ask the question.
You didn't ask?
That was the question was, is there a way of, I know you said a predisposition, but early prevention as far as,
So regular
except
checkup.
for just diet, like when you're raising a child, because with that predisposition, it's like the recommendation, okay,
So
make sure they don't eat.
So regular checkup will allow you to have early detection, and we have general practices that we can do. So, like for example, any person after 50 years of age will be taking baby aspirin to reduce the risk for stroke. So this is something general for everybody, but targeting a specific group to have certain practices to reduce the chance, I don't believe we have something in practice like this. All right, but again, everybody will need to do a regular checkup at certain age, especially if a person has a family history. Family history is going to be a much higher risk compared to a racial risk factor. Right, so if I know that my mother and father have diabetes, this puts me at a much higher risk. If I say, for example, Middle Easterns have higher predisposition to diabetes. All right, or African Americans have higher risk for diabetes, but I would have a much higher risk because my parents have diabetes. So family comes first before race. So, and we are dealing with a multifactorial thing. So you cannot just rely on one factor by itself. All right? Questions? All right. So again, why would I have developed? What is the risk factor for developing hypertension? Is deposition of fats in the walls of the vessels, and this will cause the irritation, fibrosis, atherosclerosis of the vessels, will reduce the ability of those vessels to expand, and if I reduce the ability of those vessels to expand, I would be increasing the pressure. All right, so how will I be able to diagnose hypertension? If I find blood pressure is 140 over 90 millimeter mercury, this is high blood pressure, hypertension. But can I say that this person has hypertension just with one reading? So I didn't meet him one time in my life. His blood pressure is 140 over 90, so you're hypertensive. No, you need to consider taking multiple readings in different times of the day in different circumstances. Because blood pressure will be affected by emotions, will be affected by a lot of things. So you cannot say if this patient is hypertensive unless you get multiple readings in different circumstances. All right, so moving on to shock. What is shock? So who is in shock?
The vessel.
Who is in shock?
The vessel. Blood.
actually your organs didn't believe that you're going to be supplying them with enough oxygen and nutrients, but you failed them. So they are in shock. So simply speaking, shock means low tissue perfusion. Drop in the tissue perfusion. So what might cause shock? What might cause shock? Might be because, for example, I've lost blood. I did bleed, and as I bleed, I'm losing the blood volume, and as I lose blood volume, I will have a reduction in my blood pressure, and if you have reduction in the blood pressure, you're going to have a drop in your tissue perfusion. This is what we call hypovolemic shock. Emia is blood. So hypo is low. So this is low blood volume shock. Hypovolemic shock. So hypovolemic is going to be due to hemorrhage, for example, or if I have excessive vomiting and diarrhea. If I'm losing large amounts of fluids. So what's going to happen if I have diarrhea, if I have excessive vomiting, what's going to happen? I would have hypovolemic shock, and that's why lots of people that die because of cholera. What is the problem? Diarrhea, hypovolemic shock. All right? Yes. Extensive burns. So why extensive burns will cause hypovolemic shock? And actually, if you remember back when we did discuss in the skin, back in AP1, we did mention that the first thing you need to do for patients who've got burns, extensive burns, is to give them IV fluids to maintain their blood pressure. What happens in case of burn? If I have an extensive burn, if I have lots of cells in here, some of them are going to be ruptured. And they will start to release their contents to the outside. So now the intracellular contents are going to be released to the outside. So what's going to happen to the amount of solutes present on the outside of the living cells and your blood vessels? What do you think? So if you did kill lots of cells, you did release all of the cellular content to the outside. So this will increase the amount of solutes in my extracellular fluid compared to my blood, compared to my cells, my living cells. So who loves to go from low solute to high solute concentration?
So, water.
Water by osmosis. So in case of burn, I would be oozing fluids to the outside. Why? I have lots of dead cells. They did release all their intracellular contents, creating a hypertonic medium. And as I create this hypertonic medium, I would be pulling the water out of my blood vessels to the outside. And as I keep losing water, what's going to happen to my blood volume?
Increases.
And as you drop your blood volume, what's going to happen to the tissue perfusion? Decreases. And what do we call the decrease in the tissue perfusion? This is what we call shock. Why did you get this shock? Because of low blood flow, hypovolemic shock. What if I am allergic to fish, let's say, and I did eat fish? So how my body will react against those antigens, which I am hypersensitive to? I will have extensive inflammatory response. And what is inflammation? So if I told you I have an inflamed joint, so how my joint will look like?
Expanded.
swollen, it's gonna be
Large.
large, swollen. What else? Red, hot, tender. So if I told you inflammation, what comes to your mind? 4 things.
Pain.
It's red, swollen, hot, and tender. So what causes all this is that you've got more blood supply. And how do I get more blood supply? At the site of inflammation, you dilate the vessels at the site of inflammation. So when we say inflammation, this directly means vasodilation. So why it's red, why it's hot? Because you're getting more blood to the site of inflammation. So you see on here, if I am sensitive, I have hypersensitivity against fish. So what's going to happen when I get exposed to fish? I will be responding, and my response is going to be extensive vasodilation. I have cells which will be releasing large amounts of inflammatory mediators which will cause extensive vasodilation of my vessels. And if you dilate the vessels, what's going to happen? What's going to happen to your blood pressure if you dilate the vessel? Can you remind me what's blood pressure? Equals to peripheral resistance. And what creates your peripheral resistance is the artery itself. So if I told you that you're going to be releasing large amounts of inflammatory mediators, you're going to have extensive vasodilation, all the vessels are dilating. So do you have high or low resistance now?
Low.
Very low resistance. So if this drops down, what's going to happen to my blood pressure as a result? Drop. And if you have a drop in your blood pressure, what's going to happen to your tissue perfusion? It will be decreased. And this is what we're going to call shock. What is the reason for the shock in here? Do I have a drop in my blood volume? Did I lose any blood? No. The cause for the shock is your vessels. It's called vascular shock. Vascular shock. Another reason for shock is going to be generated due to defect in the heart. So I am a cardiogenic shock. If, for example, I have myocardial infarctions, I have multiple myocardial infarctions, so what's going to happen to the force of contraction of my ventricles? If I've got multiple myocardial infarctions, what's going to happen to the force of contraction? Decrease. And if you reduce force of contraction, what's going to happen to your stroke volume? The amount of blood that you pump per beat. So what's going to happen to the stroke volume? Decreases. And when you decrease stroke volume, what's going to happen to your cardiac output? Decreases. And when you decrease cardiac output, what's going to happen to your blood pressure? Decreases. And when you drop your blood pressure below normal, what's going to happen to you? The tissue perfusion
Decreases.
drops down, and this is what we call shock. So what is the reason for the shock? It's going to be your heart. Cardiogenic shock. What else might cause cardiogenic shock? And all the reasons for the heart failures that we discussed. Having dilated cardiomyopathy, having all those reasons might end up in a cardiogenic shock. So again, what are the 3 reasons, the 3 types of shock, the 3 main types of shock? Hypovolemia, you did lose blood volume, and so your blood pressure drops, decreased tissue perfusion. Second one, is vascular shock. It's like the anaphylaxis. In case of anaphylaxis, I have hypersensitivity, I have exaggerated immune response against something which is harmless. I will be releasing large amounts of inflammatory mediators, and as a result, I will have extensive vasodilation. This extensive vasodilation will drop my resistance, and as I have a drop in the resistance, will have a major drop in my blood pressure. And if you don't have enough pores to push the blood, what's going to happen to the tissue perfusion? It drops. This is what we call shock. This is why vascular shock. The third reason for the shock is going to be cardiogenic shock. Cardiogenic shock, like having multiple myocardial infarctions, this reduces the force of contraction, and if you're not able to push the blood out in each beat, this reduces the amount of blood that you're going to be pumping per minute, dropping your blood pressure, and so your tissue perfusion. Type of shock here is cardiogenic shock. Questions? All right, so what is the single most important factor? Single most important risk factor for developing atherosclerosis. How atherosclerosis will look like. I'm accumulating fat in the wall of my arteries. If I've got a rupture of the atheromatous plates in here, I might get myocardial infarction. It will affecting one of my pulmonary vessels. All right. So, what is the single most important risk factor for atherosclerosis? Can you guess? If I told you, for example, that you have high fat diet, high carb diet, not exercising, what else? Smoking. Which one is the highest risk factor for developing atherosclerosis? Poor diet, fats, carbs, poor exercise, which one?
Poor diet.
All of them.
All the above.
So all of them are risk factors. All of them are risk factors. Yes. What is the single most?
Fatty diet. Cholesterol.
Smoking doesn't build the fat in your own body, so it's not smoking.
Yeah, it doesn't have cholesterol. It doesn't have fat.
That's the
Diet,
fat.
poor exercise, sedentary life.
It affects your metabolism. It
Yeah,
speeds
but
your.
it doesn't build
In
fat.
fact, it speeds your metabolism. It's a stimulant, so it speeds up your metabolism as well. So eventually, it burns it off.
Remember we talked about the circulation?
Yeah.
For respiratory, for your
It seems as though you are
With that one thing
against
against the whole shit of other things.
Alright, so the single most important risk factor that I was trying to show you is smoke.
What?
He was right. Told you. I give it to you, man.
Wait, elaborate.
Hey.
Elaborate.
Yeah, I want to know about this one. Because this dude made me feel like a chump 2 seconds ago.
This will cause irritation of the lining, the inside of the vessel, which increases the risk for deposition. Because deposition of the fat won't take place if I didn't have lining. So if I have a disruption of the lining of the vessel, this is a good side of the fat.
Yeah. I give you on that one. I was wrong.
Extra credit, I needed credit.
But hey, I'm glad I learned.
That's what most of us you ever notice when you work out I don't do your thighs, carry most of your
They got all this weight on top. Pushing down.
My amazing.
Probably when you stop moving, that's when most of your fat come down.
Is it break time?
Yeah.